Great. Thanks, Chairman, and thanks, GIS, for the invitation. Thank you, Dr. Ahmed Imam, for introducing my topic. Basically, calcified nodules, as we know, can be a nightmare in the cath lab, and it's completely different animal than other type of calciums. So it deserves a talk by itself, have no disclosures. So at the beginning, I'm just going to show you 4 cases, and then we're going to talk a little bit about calcium nodule, and after that, we'll see how we tackle them. This is a patient who came in with unstable angina, with calcified nodule in the proximal LAD. This is another patient who came with stable angina, and you can see in the distal RCA, a couple of calcified nodules as well. This is a patient who came in with NSTEMI with heavily calcified vessels, with a huge filling defect in the hinge point. And that's a patient who came with NSTEMI as well. We can see probably this is a lot of calcium, but we don't see as obvious calcium nodule as the prior cases. So we're going to come back to these cases, and we're going to see how we manage them differently. So what is calcified nodule is basically a nodular calcification that protrudes into the vessel and usually has a convex or at least irregular shape. The eruptive calcium nodule, luckily, it's not that common in terms of ACS. It's around 5 to 10%. But if you do have a calcium nodule in your ACS, that's just your worst enemy at that point. It's not uncommon within the calcification. So if you have chronic calcification, up to 30% that these chronic calcifications will have calcium nodule one way or the other. There are a few types of calcium nodule, actually. I learned that during preparation of this presentation. So it all depends on the opposite side of the calcium nodule. So type 1 is basically no calcification in the opposite side. Type 2, wide calcification in the opposite side. Type 3, narrow calcification, and type 4, multiple nodules, and type 5, when there is a clot. If you ask me what is the clinical implication for that, I think this is yet to be determined. The location, usually, it favors bifurcations and hinge points. That's why at the angles, usually you see calcium nodules more, and that's unfortunately is the worst place because of the deliverability issues, basically crossing. Mid-RCA would be the common one, followed by mid-LAD. The impact is there, unfortunately. This is comparing calcium nodule versus calcification without a nodule, and it does have a worst outcome in terms of MACE. That has been proven in multiple studies. If you have a calcium nodule in your chronic calcifications, that will increase your risk of MACE and TLR. There are multiple options for treatment. I'm not going to go through them. I want to just say one thing about algorithms. We have a lot of algorithms, as Dr. Ahmed Imam showed. However, most of these algorithms, especially in the nodular calcifications, are not based on rich data. It's a lot of it based on experience, and if you can see here in the nodular side, it says directly to orbital or rota, and the IVL is still investigational. So let's go back to our cases. So this patient, we did an IBIS for him. You can see the still images on the right side, the nodular appearance of the calcification, and you can see it in the run. There is heavily calcified vessel. So in this cases, we opted to use rotablation, and this is the angio after rota, debulking the calcium nodule, giving us a space to kind of be more comfortable ballooning and placing our stent, and that's the final results. I want you to see something that has been shown in all the prior cases in this session. You will never see, or rarely you will see, heavily calcified vessel with a calcium nodule that will expand to your satisfaction. It's not going to be perfect. That's okay. You're going to see a little bit of under-expansion, but as long as you prove that you have an MSA of more than 80%, I think that's good enough. Second case, this is a distal RCA calcium nodule. After we did an OCT, in this case, it shows a very nice couple of nodules in the distal RCA, but the vessel itself is quite big. So in this case, to get the maximum luminal gain, we choose orbital atherectomy. You can see here in ballooning, sometimes the balloon will expand with you. Doesn't mean that the balloon is actually expandable. The balloon is actually just pushing the calcium nodule outside of the vessel, because the adventitia is basically very elastic structure. So we did orbital atherectomy. In this case, we were happy with the stent and OCT post showing an expansion more than 80%. There is one point where there is a little bit of pinching. So we came back in that spot and we hit it again with a good final results. Again, I'm not shy to say this, but you're always going to see that waste that's going to keep bothering you. Should I do more or should I do not? And we're going to talk about that. So this year, we see more papers about using IVL for calcium nodule, and this one, I believe, by Ziad Ali, and they proved that shockwave actually might have a role in calcified nodules with a good MSA post IVL in the treated vessels. So we said, you know what, since we have some sort of evidence that this might work, let's find the case. So we got this case. It's an NSTEMI. There is a calcium nodule, but we wanted to study this case more thoroughly. So you can see here, there is a significant waste in the balloon. So we actually, for educational purposes, for our fellows in the cath lab, we did both. We did IVUS and we did OCT, just to study this calcium nodule specifically. So I'm going to show you the run here, but then we're going to see the still images. So on the left side, you're going to see the IVUS. You obviously see the calcium nodule, but we know OCT has a better tissue characterization. And the OCT is actually, this calcium nodule is not that bad. It's small. The calcium density is not that bad. So we felt more comfortable to use shockwave in this scenario. So indeed we did, and we had a good results. So this is post shockwave and stenting, as you can see here, with an expansion more than 80%. And this is the final results for the patient. So we get carried away by that, and we said, okay, shockwave is going to work actually in calcified nodule. So let's find another case. So we got this case, and you can see here how the balloon is pinched. And after we did the IVUS, this is kind of a different calcified nodule. This is more protruding, has more irregular shape, maybe pointy a little bit. But since we have a little bit of evidence and we had one case experience for shockwave and calcified nodule, we said, okay, let's just go ahead and do it. Indeed, we did the first shockwave, worked fine in the distal vessel, but then in the proximal vessel it ruptured. And after rupturing, the vessel actually had a dissection and a shutdown. So immediately we just went with our stenting and we started stenting. And after stenting, as was shown in prior presentations, that there was a significant waste, unfortunately, with the calcium nodule protruding inside the stent. So we used the third shockwave in order to expand post-stenting. And this is what we call a rota regret. Basically, if we went with rota at the beginning, all of this could have been saved, and we could have saved a little bit more money as well. So in conclusion, there is still a lot to learn in terms of the calcium nodule and calcium management overall. I think there will be lots of papers talking about the calcium volume in a specific area, score, the density in a specific area. As I showed you here, I intentionally choose cases that we use different imaging modality for. So meaning there is IVUS Boston, there is IVUS Volcano, there is OCT. All of these at your disposal. Just pick one, it will give you some information. Angio by itself is not enough. The treatment option, there is still a lot of room for improvement. I think rotablation coming with a bidirectional burr. The IVL is coming with better deliverability of the balloon, and etc. IVUS is going to come with AI to analyze the calcium as well. All of these are coming down the pipeline. Be careful using these algorithms. See what you are comfortable with, which device are you comfortable with, and stick with that. All of them will give you a little bit of benefit to address these lesions. These algorithms, based on my personal review, are not based on rich data. IVL can be a viable option, but as we saw in the last case, I think we have to be careful a little bit in which case we should use it for. And in all the cases, either in my presentation or the prior one, none of these stents will expand to 100%, especially if there is a nodular calcification. So do not aim for perfection, because the results can be catastrophic, as we know in the cath lab. and just be happy with 80% expansion. All right? Thank you.